My group in Vienna has three areas of interest. One is co-infection, as you saw this morning, and another one is portal hypertension, which I will not be talking about, and the third one is liver cancer, that I'm very much involved with at the moment. So the topic of this talk is antiviral therapy and liver cancer. And this talk will actually be dealing with two issues. The one will be prevention of HCC through antiviral therapy, and the other one will be treatment of viral hepatitis during the treatment for hepatocellular carcinoma. Now, of course, the more important one is prevention of development of hepatocellular carcinoma through antiviral therapy. So when you look at the maps of different etiologies of viral hepatitis, you can see that if you put the map for hepatitis B and the map for hepatitis B together, both of them on the lower panel, then you will get the map of HCC mortality on top, which means that these two etiologies on a global scale are the most important etiologies for liver cancer. And therefore, treating viral hepatitis is something that will be able to prevent the development of liver cancer. Now, the incidence of liver cancer is increasing, at least in certain countries like the United States, but also in Europe. And that most likely this increase in the last 10, 20 years is due to the epidemic of chronic hepatitis C, while the incidence in other countries in Asia is more or less stable or decreasing due to the fact that hepatitis B is occurring at a stable or a declining level. So definitely this is something that we can do something about by preventing it through treatment. Now, when you look at the mechanism of carcinogenesis, you can see that you have hepatitis B and hepatitis C as very prominent causes of liver cancer because they cause liver inflammation. And inflammation leads to destruction of liver cells, which leads to proliferation, scar formation, and in the end it leads to malignant transformation of cells, which then will become a hepatocellular carcinoma. And I mean, when I did, together with Yulia Bisovskaya from RONTS, we did an analysis comparing the HCC patients in Moscow and in Vienna. It was quite striking that your percentage of viral hepatitis cases was much higher than our Austrian cases, because our main etiology is alcohol, and I thought it would be the same in Russia, but obviously alcohol doesn't do anything to Russians, so we were surprised. Anyway, viral hepatitis is very important to you, and therefore prevention of inflammation by antiviral treatment is something that can prevent development of liver cancer. So here we start with hepatitis B, and here we got quite good data from Asia. This is a famous study from Asia, data from insurance companies, fairly large numbers, as you can see, 3,600 patients on the left-hand panel, which shows that there is a direct correlation between the viral load and the incidence of liver cancer. And the interesting thing on the right-hand panel is that even if you look at the patients that have completely normal transaminases, which means no inflammatory activity or minimal inflammatory activity, you still have a very high incidence of liver cancer depending on the viral load. And this led to the concept that you're not looking at transaminases that much anymore when you decide on the treatment of liver cancer, but you look at the viral load, which means even patients with normal transaminases you would treat if they have high viral loads in order to prevent liver cancer. Now, as an example for how to treat that, these are the data from lamivudine, because it was the first and the most studied drug. And as you can see here in this landmark paper from 2004, lamivudine is well able to prevent decompensation and death due to HBV-associated cirrhosis, and it's also able to prevent the development of HCC to a similar extent. Now, when you look at this in a meta-analysis here, published this year, just a few weeks ago electronically, you can see that when you look at, these were 49 studies included here, open-label to randomized controlled trials that had chronic hepatitis B, more than 2 years follow-up. And then you can see, of course, most studies were done with lamivudine, followed by adefovir, followed by entecavir, and then you had only 2 studies with telbivudine and 2 studies with tenofovir. But the overall result on the left-hand panel is that antiviral therapy in the meta-analysis prevents the development of liver cancer. And when you look at the right-hand side, on the top panel, you will see that all of these drugs do it to a similar extent. When you look at the middle panel, then HCC development is associated with liver cirrhosis. It does rarely happen in chronic viral hepatitis, and it's also dependent on the stage of cirrhosis. On the lower hand panel, you can see, of course, that lower left-hand panel, that if you have positive DNA, the risk is significantly increased. And this is something which should tell you that reducing the viral load to undetectable level is a target that we want to achieve in the treatment of chronic viral hepatitis B. Now, when we move to chronic hepatitis C, you can see here the natural course. So once your patients develop chronic hepatitis, especially once they develop cirrhosis, then they are at increased risk of developing HCC with a probability of around 3% per year. And therefore, of course, you can try to prevent the development of HCC once you have cirrhosis, but more importantly, you should prevent the development of cirrhosis once you got infection. And that you can do by treating the patients with antiviral treatment for hepatitis C, as you know. So when we look at the data from the HALT-C trial, you might recall HALT-C was a large trial around 1,000 patients that used interferon over 4 years in patients that had liver cirrhosis from hepatitis C and were not able to be cured. And the goal in this trial was that by continuously treating them with interferon monotherapy to prevent the development of HCC, which unfortunately was not able, but from this trial, you could see that the development of HCC is associated with the stage of liver disease, meaning that if you have cirrhosis and varices, then it's very likely you have a very high risk of developing HCC. When you have fibrosis and varices, it's still increased, but less. And if you have cirrhosis no varices, it's less. And fibrosis no varices is the least. And of course, even less it is if you don't have any cirrhosis, but this could not be studied in this trial because there were only cirrhotics in this trial. Again, if you look at portal hypertension as predictor on the right-hand panel, you can see here platelet count as a surrogate marker for portal hypertension. And what you see is the higher the portal pressure, the higher the risk of developing HCC. And portal pressure here is a surrogate marker for duration of liver disease, actually. Now, also for hepatitis C, it has been shown that treatment blocks cirrhosis progression and blocks the development of varices on the left-hand panel in a prospective trial where you can see patients that achieved SVR versus patients that did not achieve SVR. And on the left-hand panel in decompensated cirrhotics, you can see that if you achieve SVR in those patients, survival is very good. But if you don't achieve SVR, then those patients have a tendency to die fairly quickly. Now, in a very large series 2 years ago, over 16,000 or almost 17,000 patients, it was shown that independent of the genotype, if you achieve sustained virologic response, it reduces mortality in HCC patients, and that gave us even more impetus to really treat all the patients that we can find. And very recently, only a few months ago, this manuscript was published, which was a collaborative effort of several European centers, but also Canadian centers, which showed that sustained virologic response in hepatitis C reduces mortality, liver transplant, but also HCC. And you can see on the left-hand panel liver-related mortality or liver transplant. Of course, a big difference between patients with SVR versus those without SVR. And on the right-hand panel, the development of hepatocellular carcinoma again, if you achieve SVR, very low rate. If you don't achieve SVR, significantly higher rate of development of HCC, which again proves that treatment of hepatitis C is a very important means of reducing the development of HCC. And again, here a meta-analysis published in 2010 of 20 studies, over 4,700 patients, showing that both therapy versus no therapy, and of course SVR versus no SVR, in any case where you treat and achieve an SVR, you will be able to prevent the development of liver cancer. Now, prevention is, of course, the best thing to do, much better than treating HCC. But, of course, what shall you do if you already have a patient with HCC and you treat him for his HCC? What will you do in terms of antiviral therapy if he's got his HCC due to viral hepatitis? So this question is not as clearly answered as the one of prevention. So when you look at the EASL guidelines and the diagram of treating liver cancer, you will see an algorithm that's termed the BCLC treatment algorithm, stands for Barcelona Clinic Liver Cancer. And here there should be a line which you don't see because I wanted to show you that, but I can't because I don't have a pointer here. Basically, what's called very early stage 0 and early stage A is what will be termed curative treatment. Those are the two columns on the left-hand side, and those have to be distinguished from the intermediate stage B and the advanced stage C and the terminal stage D, which are the three columns on the right-hand side. And basically, you can imagine there's a line between these two, and everything that's on the left-hand side is things that what we call curative treatments. And the handling of viral hepatitis is somewhat different for the curative treatments than for the palliative treatments. It's not really true for hepatitis B, but it's true for hepatitis C, because in hepatitis B, you basically will treat all the patients that have hepatitis B, irrespective of the stage. And of course, we could discuss whether it really makes sense to treat terminal stage patients, but we usually would do that. While in hepatitis C, you will treat curatively treated patients that are free of tumor, at least for some time. And you will not treat patients that receive palliative treatment. And palliative treatments are TACE, sorafenib, and best supportive care. So how do I come to tell you that? Well, this here is the pattern of recurrence after curative treatment, especially after liver resection and radiofrequency ablation. So what you see is there's two peaks of liver cancer recurrence. One is within the first year, and this is true recurrence due to the fact that sometimes not all the tumor is removed. You might not see micrometastasis, or you might have incomplete removal with a positive margin, and then you'll get an early recurrence within the first year or the first 2 years. And you have to distinguish from that late recurrence, which happens after 4 or 5 years, which is basically not residual tumor, but late recurrence is mostly due to de novo tumorigenesis. You know, in a liver that's cirrhotic and has some inflammatory changes, you can always develop a new tumor, and that's what the second peak is. And of course, with regards to treatment, those can be viewed differently. And that has been shown quite nicely in this paper here, where people looked at the recurrence of hepatitis B-related liver cancer in 193 HCC patients with hepatitis B-associated liver cancer. And when they looked at factors associated with early recurrence within the first 2 years, those were mostly tumor-related factors like multinodular HCC, vascular invasion, an elevated AFP, and a cut margin that was less than 1 centimeter. So all tumor-related factors. But the late recurrences, more than 2 years after the treatment, those were most notably associated with viral hepatitis-associated factors. So, for example, if you had Ishak inflammatory activity more than 6, this would indicate significant inflammatory activity, and a high inflammatory activity would be associated with a much higher rate of recurrence than a low inflammatory activity. and that's what you can see on the graph in the top panel. Multinodular HCC would be a risk factor, and also HBV DNA, more than 2 times 10 to the 5th unit per milliliters, and that's what you see in the lower hand graph. Shows you also a nice separation of the late HCC recurrence in hepatitis B patients with low versus high viral load. So this is also, again, a very strong argument that if your patients have been resected or treated with radiofrequency ablation, then these patients definitely need some hepatitis B treatment with a nucleoside or nucleotide analog. I'm not talking about liver transplantation, but for liver transplantation, this is of course proven for the longest time, because liver transplant for hepatitis B associated liver failure, or HCC, was a very deadly disease with a very poor outcome until we had treatment for hepatitis B. And now with the treatment of hepatitis B, liver transplant for hepatitis B associated problems is not a problem anymore. So it's not astonishing that the second peak, the late recurrence, is really prevented by antiviral treatment, because when you look at the tumor development, then you'll see that inflammation plays a key role in tumor development, and that's what we try to prevent when we try to prevent late recurrences. Now, here's another very recent paper from this year looking at the anti-hepatitis B therapy post-TACE or post-resection in almost 600 patients from China. Again, here lamivudine, adefovir, entecavir, and telbivudine were used. And the authors looked at HBV reactivation and liver deterioration as 2 factors. So on the left-hand panel on the bottom, you can see that HBV reactivation can be prevented very well in both in the TACE group and in the resection group to basically 0 if you treat those patients, while you have 15 to 20% reactivation if you don't treat those patients. And when on the right-hand panel you look at liver deterioration, you can see that the rate of liver deterioration after TACE is around 8%. It's 4% in resected patients, and this can be significantly reduced to very, very low levels with anti-hepatitis B treatment, again showing that both in the curative setting of resection, but also in the palliative setting of TACE, if your patient, because with TACE, patients usually live a median of 2 years, which is actually quite a good time, and even in those patients you can prevent deterioration of liver function and probably ultimately improve survival as well. Now, hepatitis C is more difficult. In the curative setting, like with liver transplantation, of course, we treat patients after transplant if there's recurrence. Resection and radiofrequency ablation, I don't know any data, but my personal approach here is that I usually wait for a year until I see that there is no early recurrence, and if there's no early recurrence, then I tend to treat the patient for his hepatitis C. In the palliative setting with TACE or sorafenib treatment, I don't treat the patient for his hepatitis C because usually disease progression due to liver cancer is much faster than disease progression due to hepatitis C, and the treatment for hepatitis C, at least at the moment, is still a significant problem for those patients, and I don't think it's warranted, but this might change with future treatments. Now, what I want to show you here in the last 2 slides is that, of course, with sorafenib treatment, there was one quite remarkable finding, and that was when you looked here at the group of the hepatitis C patients, you could see that the hepatitis C patients seemed to do especially well with sorafenib treatment, which means that the positive effect of sorafenib treatment seemed to be especially large in hepatitis C patients. And this is not only exemplified here in this post hoc analysis from the SHARP trial, but also you might be aware of it or you might not be aware of it, that there was a combination trial of sorafenib with doxorubicin in the US, which showed a very, very long survival, also again over 14 months in mostly hepatitis C-associated patients. So this seems to be an etiology that might do especially well with sorafenib treatment. And when you look at the possible mechanisms, then I can show you here a manuscript showing that sorafenib, which is a multikinase inhibitor, seems to have actually also quite a good anti-HCV activity, because sorafenib is a CRAF inhibitor, and the HCV NS5A protein interacts with CRAF. So sorafenib has been shown here on the bottom left and middle panel to block HCV replication in the dose-dependent manner, to block gene expression, and to block NS5A hyperphosphorylation, which is important for its function. And it has also been shown in this study that other multikinase inhibitors, like sunitinib and others, don't do that. So this is really a specific action of sorafenib. And on the right-hand panel, you can see HCV viral loads in 3 patients before and during treatment with sorafenib, and you can see there's a significant drop of 3 to 4 logs in hepatitis C RNA, and that confirms, even in patients, that there is some anti-HCV activity. Now, I don't know whether this really is the effect why patients on sorafenib with hepatitis C seem to do very well, but it could be an explanation for this phenomenon. So in summary, antiviral therapy for both hepatitis B and C can prevent progression of liver disease. Antiviral therapy for both hepatitis B and C can prevent HCC development and survival. Antiviral hepatitis B therapy improves survival. Post-curative therapy for HCC, like resection, transplant, or radiofrequency ablation. And antiviral HBV therapy reduces liver deterioration after resection and TACE for HCC. Now, interferon-based HCV therapies do not play a role in the palliative treatments for HCC, but HCV treatments after curative treatments might be reasonable, as I said, after resection or radiofrequency ablation if the patient does not have an early recurrence. And the whole picture might change with new DA-only based regimens, because there might be an increasing role for HCV treatment not only in the curative but also in palliative situations with reasonable survival expectancy, but of course cost will here play a role. So finally, if you're interested in the topic of HCC any further, I would like to invite you to our meeting in 2 weeks on liver cancer management, the 2-day meeting